Welcome back to the Deep Dive. Today we are taking on one of the most challenging and really critical areas in modern medicine, mastering the complexities of childhood malignancies.
That's a huge topic.
It really is. And our listener wants to move beyond just the basics, They want to truly understand the distinct biology, the diagnostic challenges, and these highly specialized risk-stratified treatments that have, well, completely redefined pediatric oncology.
Right.
Our mission here is to extract the knowledge needed to reach, let's say, an elite professional level of comprehension on this.
Okay. Well, it's a profound area, and it's characterized by a unique paradox, really. If you're aiming for that elite level, the very first insight is that pediatric cancers are fundamentally different from adult cancer.
How so, exactly?
Well, while they're often highly aggressive, growing very rapidly, they're also generally extremely chemosensitive. Very responsive to chemotherapy.
Ah, okay, so that's the distinction. Aggressive but responsive.
That's it. Aggressive behavior countered by a high response to intensive systemic chemo. That's the bedrock, really, upon which these cure rates, often exceeding 80% in developed nations, have been built.
That success story is incredible.
Yeah.
But the sources immediately highlight the core challenge that still seems to define the field. Early detection.
Absolutely.
I was really struck by how often the early signs of malignancy are just, well, non-specific. They look exactly like routine, benign illnesses any kid might get.
That's the diagnostic trap, that inability to differentiate. When you look at the clinical features that can mask malignancy, the overlap is it's staggering.
Like what specifically?
Well, think about a child presenting with, say, fever, enlarged lymph nodes, maybe just general malaise, feeling unwell.
Right, could be anything. A virus.
Exactly. A doctor naturally thinks of common infections, but those exact same symptoms are also the presentation for a whole range of malignancies. Leukemia, lymphoma, Ewing sarcoma, neuroblastoma, even Langerhans cell histiocytosis.
Wow. And it gets even more alarming when you think about symptoms pointing to the central nervous system. I found it quite jarring in the sources that things like a chronic headache, nausea, vomiting, even new seizures.
Things you might blame on the flu or a minor bump.
Exactly. They could actually be the first sign of a primary brain tumor or maybe CNS involvement from leukemia.
So the clinical index of suspicion, it just has to remain high, especially if symptoms persist or they progress quickly.
Okay.
And then, of course, you have those classic site-specific warning signs. They're rare, but you absolutely cannot miss them.
Such as?
If a child presents with strabismus, a squint or epiphora, which is excessive tearing, or maybe just the strained red eye, well, you have to immediately screen for retinoblastoma.
Oh, right.
Those specific markers are the potentially life-saving clues that kind of bypass that routine mimicry we were talking about.
Okay, let's unpack the overall landscape then. Pediatric cancer seems heavily weighted toward blood cancers and brain tumors. What's the general distribution look like?
Yeah, leukemias really dominate the profile. They account for somewhere between 30 and 40% of all childhood cancers.
That's a huge chunk.
It is. Following that, tumors of the central nervous system, the brain tumors, they're the second most common, making up around 21%. Lymphomas take the third spot at about 11%. And then the remaining malignancies, neuroblastoma, retinoblastoma, soft tissue, bone tumors, gonadal tumors, they make up the rest of the spectrum.
I found the notes on regional variations really compelling. It suggests the epidemiology isn't, uniform everywhere.
Not at all.
For instance, the source material mentions that countries like India report a significantly higher proportion of T-cell lineage, all of it, acute lymphoblastic leukemia, compared to what we usually see in Western populations.
Exactly. And that suggests a really complex interplay, maybe genetic background, perhaps different environmental exposures, or even delays in diagnosis playing a role.
Does that variation extend to solid tumors too?
It does. India, for example, has a notably higher burden of retinoblastoma, but conversely, a lower proportional incidence of brain tumors compared to, say, North America or Western Europe. So these geographical snapshots, they really emphasize that mastery requires recognizing both the universal patterns and these population-specific differences.
Right. Okay, since it dominates the statistics, let's focus right in on leukemias. How should we define and classify them for this high-level comprehension we're aiming for?
Okay. Leukemias are malignant neoplasms.
Yeah.
They originate from the clonal proliferation, basically uncontrolled growth of abnormal hematopoietic cells, blood-forming cells, usually in the bone marrow.
And this growth disrupts normal function.
Completely. The consequence is the displacement, the crowding out, and ultimately the disruption of normal blood cell production. That leads to bone marrow failure.
And the classification.
We classify them along two main axes. First, the cell of origin, is it lymphoid or myeloid lineage? And second, the biological behavior or natural history, is it acute or chronic?
Got it. And leading that charge is acute lymphoblastic leukemia, ALL. That's the big one.
AL is the single most common childhood malignancy, period. It represents about a quarter of all childhood cancers and, strikingly, 3/4 of all acute leukemias.
Wow, 3/4 of acute leukemias.
Yeah. It has a characteristic incidence peak, usually between 2 and 5 years of age, and this peak is typically associated with the pre-B lineage of the disease, often called common A.
Any gender difference?
Boys are generally affected at slightly higher rates, and adolescent boys in particular show a higher frequency of T-cell AL.
Okay, given its success story, let's just dwell on the impact of modern therapy here for a second.
Yeah, the trajectory of all ALL therapy it's really one of the greatest triumphs in all of oncology. Decades ago, it was uniformly fatal, a death sentence.
Right.
Today, because of these highly aggressive combination chemotherapy protocols that we'll get into, cure rates in developed countries consistently exceed 80%.
80%? That's amazing.
It really is. This is often what professionals point to when discussing the dramatic progress in pediatric cancer care overall.
Okay, now in contrast, we have acute myeloid leukemia, AML. Less common, but it sounds biologically much more challenging from the notes.
It is. AML accounts for the remaining 15 to 20% of leukemias. It involves the proliferation of precursors across multiple lineages, myeloid, erythroid, even megakaryocytic, and it's clinico-biologically more complex and far more drug-resistant than resistant. Okay.
Yeah.
Because of this inherent resistance, AML requires intensely myelosuppressive therapy, both for induction and consolidation.
And the outcomes reflect that difficulty.
They do. Even with this very aggressive approach, long-term survival rates currently hover around 40 to 50% globally. That highlights the fundamental difference in biological aggressiveness compared to all much tougher disease.
Okay, achieving that elite-level understanding means knowing the risk drivers, too.
Mm-hmm.
What do we actually know about the etiopathogenesis, the specific genetic syndromes that predispose kids to acute leukemia?
Well, while most cases remain idiopathic, we don't know the exact cause. We have identified some powerful correlations. The most famous, probably, is the link between acute leukemia and specific congenital genetic syndrome.
Like Down syndrome.
Exactly. Children with Down syndrome, due to trisomy 21, have an astonishing 15 to 20-fold increased risk of developing acute leukemia, often involving either ALL or a specific type called transient myeloproliferative disorder.
15 to 20 times higher. Wow. And beyond Down syndrome, what other genetic disorders are flagged as high risk?
We have to consider syndromes associated with defective DNA repair pathways, things like Fanconi anemia, Bloom syndrome, ataxia-telangiectasia.
Okay.
Also, Li-Fraumeni syndrome. That's caused by germline mutations in the crucial p53 tumor suppressor gene. It significantly elevates the risk of multiple primary cancers, including leukemia.
And recognizing these is important for treatment.
Critically important, because these syndromes often require modifications to therapy due to specific drug sensitivities or increased risks of side effects.
What about environmental factors? Are there known exposures that contribute?
The primary ones are ionizing radiation high doses and specific iatrogenic exposures.
Meaning caused by previous medical treatment?
Exactly. Chemotherapy administered to treat a prior cancer. High-risk agents include alkylating agents like cyclophosphamide and also topoisomerase II inhibitors, specifically drugs like etoposide and tonopazide.
How do they cause leukemia?
These drugs can directly induce DNA damage that leads to secondary AML several years after the initial treatment. We also know that industrial exposures, like to the chemical benzene, are definite risk factors.
Let's talk about the absolute power of cytogenetics in IL. This seems to be where the treatment map is really drawn. The sources stress that genetic abnormalities aren't just findings, they're the primary prognostic indicators.
That is absolutely correct. Performing conventional cytogenetics plus FIH and PCR analysis is non-negotiable in IL. It's essential, because these tests rapidly categorize patients into prognostic risk groups, and that directly impacts the intensity of the treatment they receive.
Okay, so let's start with the good news. What are the best predictors of success?
The two defining features of an excellent prognosis are, first, hyperdiploidy. That's where the leukemic cells have more than 50 chromosomes instead of the normal 46.
Okay.
And second, the specific translocation, T1221. This fuses two genes, ETV6 and RUNX1. Patients with either hyperdiploidy or this translocation often achieve very high cure rates with standard, sometimes less intensive protocols.
Right. And conversely, what genetic abnormalities signal high or even very high risk?
Okay, high-risk features include the translocation T119, which fuses TCF3 and PBX1. That one's associated with a greater risk of central nervous system relapse.
Hmm.
Then there's hypodiploidy, meaning fewer than 44 chromosomes. That suggests an inherently aggressive treatment-refractory disease.
In infants.
Yes, a particularly poor prognostic group are infants, babies under 1 year old with ALL. They frequently harbor this devastating Ki411 translocation involving the MLL gene, often fused with AF4. These infants have notoriously poor outcomes, often failing to stay in remission. Very tough group.
And what about the one that used to be the most dreaded, the Philadelphia chromosome?
Ah, yes. The T922 translocation. This creates the BCR-ABL1 oncoprotein. It used to define the absolute highest risk category because it drives powerful drug-resistant proliferation and is often associated with a very high tumor burden.
Used to.
Used to, because this translocation represents a landmark achievement in targeted therapy. The introduction of tyrosine kinase inhibitors, TKIs, like imatinib, these drugs specifically block the activity of that BCR-BL1 protein.
So you add them to chemo.
Exactly. Giving imatinib alongside chemotherapy has dramatically improved survival for these patients. It's shifted the outlook entirely. It's a poster child for targeted therapy.
That shift from almost certain relapse to a manageable disease based on a single molecular target.
Yeah.
That's incredible.
Yeah.
Now let's apply the same scrutiny to AML genetics.
Okay. AML classification is also critical. We sometimes still refer to the older FAB classification M0 to M7 based on morphology, but again, the genetic signature is really what matters now for prognosis and treatment.
Which subtype is most important?
The most important subtype is FAB-M3, also known as acute promyelocytic leukemia, or APML. This specific subtype is defined by the translocation T1517, which fuses the PML gene with the RAR gene, the retinoic acid receptor alpha gene.
And this is the subtype that really changes the rules, isn't it?
It absolutely does. This specific translocation makes the leukemic cells highly sensitive to a drug called all-trans-retinoic acid, or ATRA.
Which isn't typical chemo.
No, ATRA is a differentiation agent. It doesn't kill the cells directly in the traditional cytotoxic way. Instead, it forces these malignant promyelocytes to mature, to differentiate into functional neutrophils. This essentially halts the malignant process.
And the result?
This targeted therapy, often now combined with arsenic trioxide, has elevated the survival rate for APML patients to close to 90%. Again, a stark contrast to the general AML outcomes.
Amazing. What other genetic markers in AML lead to a more favorable outcome?
We look for two other key abnormalities. The translocation T821 involving ETO and AML1 genes, and inversion 16 and V16 involving MYH11 and CBF. These are generally associated with a very good response to standard chemotherapy, often achieving survival rates in the 75–85% range.
Okay. And conversely, what are the genetic red flags for poor prognosis in AML?
Poor prognostic indicators include the FLT3-ITD mutation that signals aggressive disease. Also, specific chromosomal losses like deletion 5q or monosomy 7, loss of chromosome 7.
And what does that mean for treatment?
These features often necessitate much more aggressive upfront treatment. Typically, this means involving hematopoietic stem cell transplantation, or BMT, in the very first remission, because we know chemotherapy alone is often insufficient to cure these patients.
Let's try and synthesize these biological drivers into the clinical picture now. We noted earlier that symptoms often stem from two main processes: bone marrow failure and extramedullary infiltration.
That's right. Bone marrow failure is the direct result of those leukemic blasts just crowding out normal hematopoiesis, normal blood cell production.
Leading to
This manifests clinically as pallor and fatigue, which is from the anemia, increased bleeding tendencies like petechiae, tiny red spots, or purpura, larger bruises, that's from the thrombocytopenia, low platelets, and recurrent or severe infections due to neutropenia, the low white blood cell count.
Okay. And the manifestations outside the marrow, the extramedullary involvement.
This tends to be more pronounced in AL compared to AML. Over 60% of all patients will present with generalized lymphadenopathy, swollen lymph nodes, hepatomegaly, an enlarged liver, and splenomegaly, an enlarged spleen.
And the bone pain.
Yes, we also frequently see bone or joint pain, which can be profoundly misleading. This pain is caused by leukemic cells infiltrating the periosteum, the lining of the bone. It often leads to a misdiagnosis initially, maybe juvenile arthritis or just simple growing pains, before the true malignancy is uncovered.
AML, though, has some very unique physical signs according to the sources.
That's right. While massive organomegaly is generally less frequent than in ALL, AML has some specific calling cards. Gum hypertrophy, sort of swollen, overgrown gums, is highly characteristic, especially of the M4 subtype, which is acute myelomonocytic leukemia.
Okay.
We also look for chloromas. These are localized solid tumors made up of leukemic cells. They can appear anywhere, but when they occur in the orbit, around the eye, they cause proptosis, a bulging eye, or striking periorbital bruising, leading to that clinical sign known as raccoon eyes.
And this specific risk associated with APML, the M3 subtype.
Yes, because of the underlying biology related to that T1517 translocation, acute promyelocytic leukemia is frequently associated with life-threatening disseminated intravascular coagulation, or DIC. It's a clotting disorder that causes both bleeding and thrombosis. It must be managed immediately with blood products and, critically, starting ATRA treatment right away.
This brings us directly to the risk of oncologic emergencies caused just by the sheer volume of disease.
Right. The rapid accumulation of blasts can trigger two critical emergencies. First is hyperleukocytosis. That's usually defined as a total leukocyte count, or TLC, greater than 100,000 per cubic millimeter.
And why is that dangerous?
It causes leukostasis. Basically, the blood becomes thick and sludgy due to the high number of blasts, potentially blocking small blood vessels. This can lead to life-threatening complications like stroke or acute respiratory distress. Urgent treatment, sometimes leukapheresis, is needed.
And the second emergency.
The second is tumor lysis syndrome, or TLS. This happens when these rapidly dividing cells die quickly, either spontaneously or, more often, right at the start of therapy. They burst open and release massive amounts of their intracellular contents into the bloodstream.
Causing metabolic chaos.
Exactly, a metabolic catastrophe. High potassium, high phosphate, low calcium, and very high uric acid. It requires immediate and aggressive management.
Finally, before we talk about treatment, we have to revisit the concept of sanctuary sites. These are areas where systemic chemo struggles to penetrate effectively.
Understanding these sites is absolutely fundamental to curing leukemia, especially ALL. The two main sanctuary sites are the central nervous system, CNS, the brain and spinal fluid, and the testes in boys.
Why are they sanctuaries?
The blood-brain barrier and the blood-testis barrier limit the penetration of many chemotherapy drugs. CNS involvement occurs in about 5–15% of patients at diagnosis, but it's often subclinical, meaning hidden. However, it can present overtly with cranial nerve palsies, headaches, vomiting, or even seizures.
And the testes.
Testicular leukemia happens in about 1% of boys at diagnosis. It acts as a protected niche for leukemic cells, often presenting as a firm, painless swelling. Relapse is highly likely if these sanctuary sites are not specifically and prophylactically treated, even if the bone marrow appears clear after initial therapy.
Okay, given all this complexity, let's turn to management. Diagnosis is clearly the starting line for what sounds like a 4-phase treatment marathon, especially for ALL. What are the definitive diagnostic steps?
Right. After the initial suspicion raised by the peripheral blood smear and the complete blood count, the definitive diagnosis hinges on the bone marrow aspirate and biopsy.
And the blast count is key.
Yes. For ALL, a blast count greater than 25% in the marrow is diagnostic. For AML, it's greater than 20% blasts. But just looking at the morphology under the microscope only gets you so far.
You need more detail.
Absolutely. We require immunophenotyping. This uses flow cytometry to identify specific protein markers on the surface of the blasts, telling us precisely the cellular lineage. Is it pre-B-cell ALL, T-cell ALL, mature B-cell ALL, or one of the AML subtypes?
And the genetics we talked about.
And critically, the cytogenetics, FISH, and PCR studies. These are essential to identify those specific prognostic translocations and genetic abnormalities we just spent time detailing. That information dictates the risk group and the entire treatment plan.
Okay, let's break down the 4 crucial phases of all therapy, starting with induction. What's the precise goal here?
Induction therapy has one main goal: achieve a rapid, complete remission. That's formally defined as having less than 5% blasts remaining in the bone marrow morphologically.
How is that achieved?
Modern multi-drug regimens are used. Typically, these involve vincristine, which is a microtubule inhibitor or spindle poison, prednisolone, a steroid which is directly cytotoxic to lymphoblasts, L-asparaginase, an enzyme that depletes an amino acid essential for leukemia cells, and usually an anthracycline like daunorubicin or doxorubicin.
And how effective is induction?
Highly effective. These combinations achieve remission in nearly 98% of children with SL. But a key performance indicator here is rapid early response.
Meaning how quickly the blasts disappear?
Exactly. If the blast count in the marrow is very low or undetectable by day 7 or day 14 of treatment, that is a powerful positive prognostic factor. It suggests the leukemia is highly chemosensitive and predicts a higher likelihood of long-term cure.
Okay, phase 1, induction. Phase 2 is dedicated to tackling those sanctuary sites.
Right. That's CNS prophylaxis, or CNS-directed therapy. Since we assume subclinical CNS disease might be present, even if not obvious, we must treat the CNS to prevent future relapse there.
How is that done now? You mentioned radiation is used less.
Yes, the historic standard use of cranial radiation has largely been phased out, especially for standard risk patients. This is because of the severe risks of long-term neurocognitive impairment, endocrine problems, and secondary brain tumors later in life.
So what's the alternative?
The modern gold standard is intensive, repeated intrathecal therapy. This involves injecting chemotherapy drugs, typically methotrexate, often in a triple combination with hydrocortisone and cytarabine, directly into the cerebrospinal fluid via lumbar puncture.
Is radiation ever used?
Cranial irradiation is now reserved only for patients with very high-risk features. For example, those with overt CNS leukemia at diagnosis, or perhaps those with T-cell AL and very high white counts, or those with Philadelphia-positive AL.
Got it. So after induction clears the bulk of the disease and prophylaxis addresses the CNS, how does the intensification or consolidation phase work?
Intensification or consolidation is essentially a phase of giving higher doses of chemotherapy. Even after successful induction achieves morphological remission, the body might still harbor billions, maybe 199 to $10 residual hidden malignant cells.
So this is about mopping up.
Exactly. Consolidation aims to aggressively wipe out this minimal residual disease burden. It often employs drugs like high-dose methotrexate and high-dose cytarabine given in cycles. The specifics of this phase are tailored very carefully to the patient's initial risk stratification and, importantly, their early response to induction therapy.
Okay, and then we enter the longest phase, right? The long-term vigilance.
That's maintenance therapy. This typically lasts for 24 to 30 months in total. It's a sustained, lower-intensity effort designed to prevent any microscopic residual cells from growing back and causing relapse.
What does maintenance involve?
The backbone of maintenance is typically daily oral 6-mercaptopurine, 6-MP, and weekly oral methotrexate. This might be punctuated by periodic reinduction-type pulses of other drugs like vincristine and steroids. This extended duration is absolutely essential because the risk of relapse remains significant if therapy is stopped too early.
Let's just touch on those critical high-risk subgroups again. Infant IL, especially with that T411 translocation, sounds particularly challenging.
It is. Infant IL has a distinct, aggressive biology that often resists conventional chemotherapy. That T411 translocation, which is frequent in these babies, often leads to hyperleukocytosis and very poor outcomes, with cure rates unfortunately still lingering around 30–40%.
So they need different treatment.
They demand exceptionally intense protocols, often featuring drugs like high-dose cytarabine and methotrexate. And they are usually considered for or referred for early allogeneic stem cell transplantation.
But the news is much better for Philadelphia positive on, thanks to the targeted therapy.
Absolutely. The integration of imatinib, that TKI we mentioned, with standard chemotherapy has completely revolutionized the treatment for this subset.
Yeah.
Previously, these patients had dismal outcomes, often needing immediate stem cell transplant if possible.
And now?
Now, this combination therapy, TKI plus chemo, has improved the 3-year event-free survival rate to approximately 80%. It's a prime example of the power of precision medicine, even within intensive pediatric protocols.
So synthesizing everything for all prognosis, what are the main factors that put a child at the highest risk of relapse, the really unsatisfactory prognostic factors?
Okay. The key indicators consistently associated with poor prognosis are age, being less than 1 year old or older than 10 years at diagnosis, high initial disease burden, typically defined by a leukocyte count greater than 50,000 per cubic millimeter, certain adverse cytogenetics like hypodiploidy or that T411 in infants, and arguably the single most powerful predictor of relapse today is minimal residual disease, MRD, positivity after induction.
Can you elaborate on why MRD is so critical? It's about detecting disease below the microscope level.
Exactly. MRD refers to the persistence of leukemic cells at levels below what we can see with a standard microscope, usually detected using highly sensitive techniques like multi-parameter flow cytometry or PCR for specific gene rearrangements or fusions.
And if it's positive?
If a patient is deemed MRD positive at specific time points, usually at the end of induction therapy, it means there are still small but significant pockets of leukemic cells hiding. This is a very strong molecular indicator that the initial chemotherapy wasn't fully effective, and it demands an immediate escalation of therapy, often proceeding directly to allogeneic hematopoietic stem cell transplantation, because we know that continuing with standard chemotherapy alone will likely result in relapse for these patients.
Okay, very clear. Now, let's pivot to the management of AML, which you characterized earlier as more resistant.
Yeah.
How does the philosophy of treatment differ?
AML generally requires a philosophy of extreme aggression up front, but often for a shorter overall duration compared to AL. The decision-making hinges heavily on those cytogenetic and molecular risk factors we discussed.
So risk stratification is key here, too.
Absolutely. For patients with favorable cytogenetics like APML, M3, or those with T821 or NV16, the goal is generally to cure them with intensive chemotherapy alone.
But for the unfavorable group?
For those with unfavorable features like the FLT3-ITD mutation or monosomy 7 or complex cytogenetics, the risk of relapse after chemo alone is considered unacceptably high. Therefore, the standard approach is to proceed directly to allogeneic HSCT, stem cell transplant, ideally while they are in their first remission.
What does a standard AML induction regimen look like? What drugs are used?
It's typically based on high doses of cytosine arabinoside, also called Ara-C, often given as a continuous infusion over 7 days. This is usually combined with an anthracycline like daunorubicin or idarubicin, typically given for 3 days. Sometimes other agents like etoposide are added.
And remission rates?
Remission rates after induction are decent, maybe 70–80%, but relapse is common if not followed by intensive consolidation. The subsequent consolidation therapy must also be very high dose, usually involving more cycles of high-dose cytarabine to prevent relapse.
And we absolutely must revisit the specialized treatment for APML, the M3 subtype, which you called a game changer.
Yes, the treatment for APML is really an excellent example of successful targeted differentiation therapy. These patients receive all trans-retinoic acid, ATRA, often combined with arsenic trioxide, ATO, sometimes with or followed by anthracyclines, depending on risk stratification.
And how does this combination work again?
ATRA and arsenic work synergistically. They essentially force the malignant promyelocytes to differentiate, to mature, and then undergo programmed cell death, apoptosis, rather than just killing them non-specifically. This targeted, biologically driven approach avoids much of the toxicity of traditional chemotherapy while being profoundly effective.
And that explains the high survival rates.
Exactly. This specific approach is why APML's survival rates are now so high, often over 90%. It illustrates the ultimate goal of cancer research, understanding the biology to develop highly effective targeted treatments.
Okay, let's move on to the less common chronic leukemias. CML, chronic myeloid leukemia, seems defined by that specific chromosomal abnormality we talked about earlier.
Right. CML makes up only about 3% of childhood leukemias, much less common than ALL or AML. And yes, it's biologically defined by the presence of the famous Philadelphia FH chromosome. That's the result of the T922 translocation, which creates the BCR-ABL1 fusion oncogene.
And the biological effect.
The defining biological feature is massive myeloid hyperplasia and overproduction of mature and maturing myeloid cells, especially neutrophils and their precursors.
The sources differentiate between the adult form seen in older children and a distinct juvenile form. Can you explain that?
Yes, that distinction is crucial. The adult-type CML presentation, which we typically see in children older than about 4 years, follows the classic triphasic course seen in adults. It starts with a chronic, often stable phase that can last for years. This may then transition to an accelerated phase and eventually progresses to the terminal aggressive blast crisis, which clinically resembles acute leukemia.
And how is this adult-type CML treated in kids?
Treatment here is highly effective now. It relies almost entirely on oral first or second generation tyrosine kinase inhibitors, TKIs, like imatinib, dasatinib, or nilotinib. These drugs specifically target and shut down that BCR-ABL1 fusion protein that drives the disease.
Okay. And the other form, JMML, juvenile myelomonocytic leukemia.
JMML is a completely distinct and much more aggressive disease. It affects infants and very young children, usually presenting before age 5. It has a much more rapid and severe clinical course than CML.
What are its key features?
The key hematological feature is striking monocytosis, a huge overabundance of monocytes seen on the peripheral blood smear. It's also notably associated with children who have the genetic condition neurofibromatosis type 1, NF1.
And the prognosis.
Tragically, JMML has a high mortality rate. Management often involves intensive supportive care, and currently, allogeneic HSCT, stem cell transplant, is the only potentially curative option. It's a very challenging disease.
Right. Let's move next to lymphomas, the third most common group of pediatric cancers overall. We divide these into Hodgkin, HL, and non-Hodgkin, NHL, correct?
Correct. Together, they account for about 10–15% of all childhood cancer cases. And within that, NHL is more common, making up about 60% of lymphomas, with HL accounting for the remaining 40%.
Okay, let's start with Hodgkin lymphoma, HL. What's its pathological signature? What defines it under the microscope?
The defining pathological feature, the hallmark cell, is the presence of the large, often binucleated or multinucleated Reed-Sternberg RS cell. Microscopically, it often has that classic owl eye appearance due to its prominent nucleoli.
And there's an infectious link.
Yes, HL has a strong association with the Epstein-Barr virus, EBV. EBV DNA is found within the RS cells in a significant proportion of cases, particularly the mixed cellularity subtype, and it's thought to play a role in the oncogenesis, the development of the RS cells.
And we see those geopolitical variations in the histology itself, similar to all.
We do. In higher income developed countries, the nodular sclerosing subtype is the most prevalent form of HL. However, in India and other developing regions, the mixed cellularity subtype tends to dominate, often accounting for around 60% of cases. This might reflect different patterns or timing of EBV exposure in the population.
Clinically, what's the classic presentation? How do these kids usually show up?
The vast majority, about 80% present with painless, firm, and kind of rubbery lymphadenopathy. Swollen lymph nodes, usually these are in the cervical, neck, or supraclavicular above the collarbone regions.
What about inside the chest?
Roughly half of patients also have mediastinal adenopathy, enlarged lymph nodes in the chest, which can sometimes be large enough to cause compression symptoms like cough or shortness of breath.
And you mentioned B symptoms earlier.
Right.
What are those, again, in the context of HL?
Right. B symptoms are systemic symptoms that have prognostic significance. They are specifically unexplained fever above 38 degrees Celsius, 100.4 F, drenching night sweats that require changing clothes or bedding, and unexplained weight loss exceeding 10% of body weight over the preceding 6 months.
And their presence means?
The presence of one or more B symptoms generally indicates more advanced disease and is considered an unfavorable prognostic factor, often influencing treatment decisions.
The staging system used is the modified Ann Arbor system. Why is staging so critical for HL?
Staging is absolutely crucial because it dictates the intensity and duration of therapy. The Ann Arbor system stages the disease from I through IV based on the number and location of involved nodal sites, using the diaphragm as a key reference point.
And it includes more than just location.
Yes. Critically, the staging classification includes the designation A for the absence or B for the presence of those systemic B symptoms we just discussed. We also specifically note if there is bulky disease, usually designated with an X, which is defined either as a lymph node mass larger than 10 centimeters in diameter or a mediastinal mass that takes up more than 1/3 of the transverse diameter of the thorax on a chest X-ray. Bulky disease also implies a higher risk.
Given the really high cure rate, often quoted as 85–90%, how is HL treated today? Is it still chemo and radiation?
Treatment primarily relies on combination chemotherapy. The standard regimen used for decades, and still very common, is ABVD, that stands for adriamycin, doxorubicin, bleomycin, vinblastine, and dacarbazine.
What about radiation?
Given the significant long-term risks associated with radiation, particularly secondary cancers like breast cancer after chest radiation and cardiovascular disease, there's been a major trend towards reducing or even eliminating radiation therapy whenever possible.
So who still gets radiation?
Low-dose involved field radiation therapy, IFRT, radiation targeted only to the initially involved areas, is now often reserved only for patients who present with bulky disease or those who have an unfavorable or slow response to the initial cycles of chemotherapy, based on interim PET scans. The goal is always to minimize late effects while maintaining the high cure rate. HSCT, stem cell transplant, is typically reserved for cases of relapse.
Okay, now let's switch to non-Hodgkin lymphoma, NHL, the more common type in kids, which you said presents quite differently.
Yes, pediatric NHL is biologically distinct from HL and also from most adult NHLs. It's characterized by being very high grade biologically. These tumors grow extremely rapidly. They have a very high proliferative fraction, meaning lots of cells are dividing at any given time. And they have a strong tendency to present extranodally outside of lymph nodes, often arising in sites like the abdomen, chest, mediastinum, or head and neck.
But despite being aggressive, survival is good.
Despite this aggressive nature, survival rates are generally excellent, often in the 70–90% range, provided that the appropriate intensive chemotherapy is initiated very promptly. Time is really of the essence with NHL.
Can you walk us through the key subtypes of pediatric NHL?
Sure. The main types are categorized primarily by the cell of origin. The most common type globally is Burkitt, or Burkitt-like lymphoma, BL. This is a mature B-cell malignancy, classically defined by the T814 translocation involving the MYC oncogene. In the sporadic form, common outside of Africa, it often presents as a large, rapidly growing abdominal mass, frequently in the ileocecal region. The endemic African form is often associated with EBV and jaw masses.
Okay, what's next?
Second is lymphoblastic lymphoma, LL. This arises from precursor T cells, or less commonly precursor B cells. About 70% are T lineage. TLL is characterized by often presenting as a large, aggressive mass in the mediastinum, the space in the chest between the lungs. Biologically, it's very similar to T cell LL.
Any others?
Then there's diffuse large B-cell lymphoma, DLBCL, which is more common in adults but does occur in adolescents. And finally, anaplastic large cell lymphoma, ALCL. This is typically a T-cell lymphoma, often defined by the T2 translocation involving the ALK gene, and the cells strongly express the CD30 marker. ALCL often presents with systemic symptoms and can involve skin and bone in addition to lymph nodes.
You mentioned the rapid growth. Does this mean NHL often presents as an emergency?
Yes, this is a critical hallmark of pediatric NHL. That intrathoracic mass in TLL can rapidly compress the superior vena cava, causing superior vena cava, SVC syndrome, characterized by facial and neck swelling, visible distended veins, and potentially life-threatening difficulty breathing.
And abdominal Burkitt.
Extensive abdominal Burkitt lymphoma can cause bowel obstruction or intussusception. And because of the extremely high cell turnover rate in tumors like Burkitt, NHL patients are at incredibly high risk for developing spontaneous or treatment-induced tumor lysis syndrome, TLS, often right at the time of diagnosis or upon starting treatment. These are true oncologic emergencies.
How is NHL staged and treated then?
Staging is usually done using the St. Jude staging system, or the very similar Murphy system. This system basically categorizes the disease based on the extent of spread, moving from stage I, localized single site, up to stage 4, involvement of the CNS or bone marrow. It helps differentiate between lower risk, localized, and higher risk, e.g. intrathoracic, extensive abdominal CNS marrow involvement disease.
And treatment?
Treatment requires intensive multi-agent chemotherapy, often based on complex, timed protocols originally developed by cooperative groups like the BFM, Berlin, Frankfurt, Mr. Group in Germany. These protocols are short but very intense. Critically, for the B-cell lymphomas like Burkitt and DLBCL, the addition of the anti-CD20 monoclonal antibody rituximab to the chemotherapy backbone has significantly improved survival rates even further in recent years.
Okay, let's transition now to some of the major solid tumors of childhood, beginning with retinoblastoma. This one seems entirely defined by its genetic driver.
It really is. Retinoblastoma is the most common primary intraocular tumor cancer inside the eye in children. It's typically diagnosed quite early, with 90% diagnosed by age 3 or 4, and its pathogenesis is classically defined by mutations in the RB1 tumor suppressor gene, located on chromosome 13q14.
And this is the basis for that famous two-hit model.
Exactly. Retinoblastoma was the first cancer for which Alfred Nenson proposed his two-hit hypothesis of oncogenesis back in the 1970s. It perfectly explains the two forms of the disease.
Can you clearly define the difference between the two forms using that model?
Sure. In the hereditary or inherited form, about 40% of cases, the child inherits one mutated or missing RB1 allele through the germline, meaning it's present in every cell of their body. That's the first hit. Then only a single second somatic mutation or loss event affecting the other RB1 allele needs to occur in a developing retinal cell for the tumor to form. This leads to typically early onset disease, often affecting both eyes, bilateral, and commonly results in multiple independent tumors within an eye, multifocal. These individuals also have a significantly increased risk of developing other cancers later in life, like osteosarcoma.
And the sporadic form.
In the sporadic form, about 60% of cases, the child is born with two normal RB1 alleles. Therefore, both necessary hits, mutations, or losses inactivating both copies of the RB1 gene must occur independently and somatically, acquired after conception, within a single retinal cell precursor. This requires two rare events, so it typically leads to later onset disease, almost always affects only one eye, unilateral, and usually results in only a single tumor, unifocal.
What's the visual presentation that usually prompts the diagnosis? What should parents or doctors look for?
Leukocoria, which means white pupil, is the classic and most common presenting sign. Instead of the normal red reflex when light shines in the eye, like in photos, the pupil appears white or yellowish. It's sometimes called a cat's eye reflex. This sign requires immediate referral to an ophthalmologist.
And if diagnosis is delayed?
Sadly, yes, particularly in regions with less access to specialized care, children may present with much more advanced signs. These can include strabismus, a new squint or crossed eye, proptosis, bulging of the eye out of its socket, eye pain, redness, or even a fungating, ulcerating mass growing out of the eye in very advanced cases.
Okay, how is it staged and treated? What are the goals?
Staging is done using the International Classification for Intraocular Retinoblastoma, which grades tumors from Group A, very small, favorable, to Group E, very large, extensive, often with vitreous seeding, considered unsalvageable eyes. There's also staging for extraocular disease, orbital or metastatic. The treatment goals are ranked very clearly. First and foremost is survival. Second is preservation of the eye, globe salvage. And third is preservation of useful vision.
How were those goals achieved?
For large unilateral tumors, especially group E eyes with no hope for vision, immediate enucleation, surgical removal of the eye, may be the safest option to guarantee survival and prevent spread. For smaller tumors or in bilateral disease where saving vision is paramount, the approach is often chemoreduction.
What's chemoreduction?
That involves using systemic chemotherapy, typically a combination like vincristine, carboplatin, and etoposide, VEC, to shrink the intraocular tumors first. This is then followed by focal consolidation therapies applied directly to the residual tumor, such as laser photocoagulation or cryotherapy, freezing. In some specialized centers, advanced techniques like injecting chemotherapy directly into the ophthalmic artery, intraarterial chemotherapy, are used to deliver high drug concentrations to the eye while minimizing systemic toxicity. Radiation therapy to the eye is used much less now due to late effects, but may be needed in some refractory cases.
Okay. Next up is Wilms tumor, or neuroblastoma, the most common kidney malignancy in children.
That's right. Wilms tumor typically has a peak incidence between 2 and 3 years of age. About 20% of cases are linked to germline mutations or alterations in the WT1 gene, located on chromosome 11p13. WT1 is a crucial gene for normal kidney and genitourinary development.
Which explains its link to certain syndromes.
Exactly. Its association with specific congenital syndromes often involves abnormalities of the kidneys, genitals, and sometimes the eyes. The key ones are WAG syndrome, Wilms tumor, aniridy absence of the iris, genitourinary anomalies, and intellectual disability retardation, Denise-Drash syndrome, early onset kidney failure, ambiguous genitalia, and Wilms tumor, and also Beckwith-Weidemann syndrome, an overgrowth syndrome associated with several embryonal tumors, including Wilms.
How does Wilms tumor usually present clinically?
The most common presentation by far is an asymptomatic abdominal mass. It's often discovered incidentally by a parent while bathing or dressing the child, or during a routine pediatric checkup. Other less common symptoms can include abdominal pain, blood in the urine, hematuria, fever, and sometimes high blood pressure hypertension, which is caused by the tumor-producing renin.
And there's a specific surgical risk mentioned.
Yes, a critical consideration for surgeons is the potential formation of a tumor thrombus, a clot made of tumor cells that can grow from the kidney tumor into the renal vein and extend up into the inferior vena cava, IVC, sometimes even reaching the heart. This occurs in about 4–10% of cases and significantly complicates the surgical resection, requiring specialized vascular surgery techniques.
Now, I want to pause on this point from the sources. There seem to be two distinctly different global approaches to managing Wilms tumor initially.
Yes, this is a major philosophical difference between the two largest international pediatric oncology cooperative groups. The COG, Children's Oncology Group, primarily based in North America, generally favors immediate, upfront surgical resection of the kidney tumor, nephrectomy, followed by risk-stratified chemotherapy based on the pathology and stage found at surgery.
And the other approach.
In contrast, the SIOP, International Society of Pediatric Oncology, predominantly in Europe and many other parts of the world, generally advocates for several weeks of preoperative chemotherapy before surgery, usually without a prior biopsy. Diagnosis is based on imaging.
What's the rationale for giving chemo first?
The rationale for the SIOP approach is that giving chemotherapy first shrinks the tumor, which potentially makes surgery easier, reduces the risk of tumor rupture during the operation, which can upstage the patient and necessitate more therapy, and may allow for treatment of any microscopic metastatic disease earlier. It also allows for assessing the tumor's response to chemo, which has prognostic value.
Do the outcomes differ significantly?
Interestingly, despite these different initial approaches, both strategies achieve excellent overall cure rates for Wilms tumor, generally approaching or exceeding 90% for localized disease. The debates continue about the relative merits regarding surgical complications, precise staging, and minimizing therapy for low-risk patients. Post-operative treatment for both involves chemotherapy, usually vincristine and actinomycin D for lower stages, adding doxorubicin and sometimes radiation for higher stages or unfavorable histology.
Okay, moving on to neuroblastoma. This originates from the neural crest and is often a disease of infants and very young children.
That's correct. Neuroblastoma is the most common malignant extracranial solid tumor in children, brain tumors being the most common intracranial ones. It arises from primitive cells of the sympathetic nervous system, which originates from the neural crest during embryonic development. About 90% of cases present before the age of 5, with a median age around 18 months.
Where do these tumors usually arise?
They can arise anywhere along the sympathetic chain, but the most common primary site, accounting for almost half, 46% of cases, is the adrenal medulla, the inner part of the adrenal gland sitting atop the kidney. Other common sites include the sympathetic ganglia in the abdomen, chest, posterior mediastinum, neck, or pelvis.
What does it look like pathologically?
Pathologically, it's classified as one of these small, round, blue cell tumors of childhood. A characteristic feature, though not always present, is the formation of homocyte pseudorossettes, circles of tumor cells around a fibrillar center.
And it has a unique biological capability.
Yes, quite remarkably, neuroblastoma is one of the few human malignancies capable of spontaneous regression, especially in certain low-risk infants, like stage IVS, which we'll discuss. The tumor cells can sometimes spontaneously differentiate into benign ganglion cells or even just disappear completely without any therapy.
What's the key genetic marker that determines how aggressive the disease is?
The single most important prognostic molecular marker in neuroblastoma is the amplification status of the MYCN oncogene, sometimes written as NMYCAKE.
Yeah.
Having 10 or more copies of the MYCN gene within the tumor cells is strongly associated with rapid tumor progression, advanced stage disease, and treatment resistance. MYCN amplification occurs in about 20–25% of cases overall and is a defining feature of high-risk neuroblastoma, demanding the most intensive treatment available.
Clinically, beyond the primary mass, what are some of the characteristic signs of metastasis that really stand out?
Metastatic spread is common at diagnosis, especially in older children. Some signs are quite striking. We already mentioned the raccoon eyes, that's bilateral bruising and swelling around the eyes. Periorbital ecchymosis, caused by metastatic tumor infiltrating the orbital bones.
Any other unique signs?
Metastases to bone can cause pain or limping. Widespread marrow involvement can cause cytopenias. Skin metastases can appear as firm, bluish nodules, and rarely, neuroblastoma can be associated with highly informative paraneoplastic syndrome. One is the opsoclonus myoclonus ataxia syndrome, OAS, sometimes called dancing eyes, dancing feet. This is a neurological disorder thought to be immune-mediated, causing rapid, chaotic eye movements, opsoclonus, muscle jerks, myoclonus, and loss of coordination, ataxia. Children with OMS and neuroblastoma paradoxically often have a better tumor prognosis, but may suffer long-term neurological issues. Another rare syndrome is intractable watery diarrhea, caused by the tumor-secreting vasoactive intestinal peptide, VIP.
The management strategy seems incredibly varied, reflecting this huge biological spectrum, from spontaneous regression to lethal aggression. Tell us about that special stage IVS category.
Right, management is intensely risk-based. probably more so than for any other childhood cancer. The International Neuroblastoma Staging System, INSS, includes a unique category called Stage IVS for special. This stage applies only to infants under 1 year of age who have a small, localized primary tumor, stage 1 or 2, but who also have metastatic dissemination limited only to the liver, skin, and or bone marrow, with minimal marrow involvement.
And the prognosis for IVF?
Crucially, despite having metastatic disease, infants with stage IVS disease generally have a very favorable prognosis. Many of these tumors will regress spontaneously, so treatment often involves just careful observation or perhaps minimal, low-intensity chemotherapy, only if symptoms, like massive liver enlargement causing breathing problems, necessitate it.
And at the other end of the spectrum, high-risk disease.
Conversely, children classified as high-risk, typically older children, 18 months, with metastatic disease, stage 4, or anyone with MYCN amplification require extremely intensive multimodal therapy. This usually involves 1. Multi-agent induction chemotherapy, using combinations like OPEC or cyclophosphamide, vincristine, doxorubicin, etoposide, cisplatin. 2. Surgical resection of the primary tumor. 3. High-dose chemotherapy followed by autologous hematopoietic stem cell transplantation, using the patient's own stem cells rescued before the high-dose chemo. 4. Radiation therapy to the primary tumor bed and sometimes to metastatic sites. And 5. Post-consolidation therapy with 13-cis-retinoic acid, isotretinoin, an oral differentiation agent often combined with immunotherapy, anti-GD2 monoclonal antibodies plus cytokines, to target minimal residual disease. Despite all this, survival for high-risk neuroblastoma remains a major challenge, around 50%. Low and intermediate-risk patients receive less intensive therapy tailored to their specific stage in biology.
Finally, for this section, let's briefly cover soft tissue and bone tumors, really emphasizing the critical difference between the two major bone cancers.
Okay. The most common soft tissue sarcoma, STS, in childhood is rhabdomyosarcoma, RMS, which arises from cells that normally develop into skeletal muscle. It can occur anywhere, but common sites include the head and neck region, especially orbit and perimeningeal sites, the genitourinary tract, bladder, prostate, vagina, and the extremities.
Are there different types of RMS?
Yes. Pathologically, we mainly distinguish between the more favorable embryonal subtype, which looks like developing muscle, and the generally less favorable alveolar subtype, which has a specific genetic translocation in most cases. Prognosis depends heavily on subtype, primary site, stage, and completeness of surgical resection. Localized disease often has high cure rates, frequently above 70%, achieved with a combination of surgery, radiation therapy, RMS is radiosensitive, and multi-agent chemotherapy.
Okay, now for the bone tumors. What's the critical distinction between the two major types?
The two main primary malignant bone tumors in children and adolescents are osteosarcoma and Ewing sarcoma, and they are treated very differently. Osteogenic sarcoma, osteosarcoma, is the most common. It typically peaks during the adolescent growth spurt and usually arises in the metaphysis, the growing end of long bones, most commonly the distal femur near the knee or proximal tibia, also near the knee.
Any genetic links?
It's linked to mutations in the RB1 and TP53 genes associated with hereditary retinoblastoma and Liefeld-Maney syndrome, respectively. And critically, osteosarcoma is fundamentally unresponsive to radiotherapy. Radiation does not work.
So how is it treated?
Treatment absolutely relies on achieving complete surgical resection of the tumor, ideally with limb-sparing surgery if possible, combined with intensive multi-agent chemotherapy given both before neoadjuvant and after adjuvant surgery. Standard chemo agents include high-dose methotrexate, doxorubicin, adriamycin, and cisplatin, MAP chemotherapy.
Okay, unresponsive to radiation. Now the mirror image, Ewing sarcoma.
Ewing sarcoma is the second most common bone malignancy. It typically occurs a bit later, often in the second decade of life. Unlike osteosarcoma, it often arises in the diaphysis mid-shaft of long bones or in flat bones like the pelvis, ribs, or scapula.
And its defining features.
Pathologically, it's another small, round blue cell tumor. It's pathognomonic, meaning diagnostic, for a specific chromosomal translocation, most commonly T1122, which fuses the EWSR1 gene with the FLI1 gene. On X-ray, it can produce a characteristic onion skin periosteel reaction, layers of new bone formation.
And the critical treatment difference.
Critically, unlike osteosarcoma, Ewing sarcoma is highly responsive to both chemotherapy and radiotherapy. Therefore, multimodal management is essential. Treatment typically involves multi-agent chemotherapy, often including vincristine, doxorubicin, cyclophosphamide, efosfamide, and etoposide, combined with local control measures which can be either surgery, radiation therapy, or often a combination of both, depending on the tumor's location and size and response to chemo.
Okay, next section. Brain tumors are the second most common type of malignancy overall in children and the most common solid tumor. In kids, the location of the tumor seems absolutely paramount to the clinical presentation and management.
Location is absolutely destiny in pediatric neuro-oncology. You're right. In children, a majority of brain tumors, about 60%, arise infratentorially, meaning in the posterior fossa, the area containing the cerebellum and brainstem, below the tentorium cerebelli.
And why is that location significant?
Because tumors in this confined space are much more likely to obstruct the flow of cerebrospinal fluid, CSF, leading to hydrocephalus and symptoms of raised intracranial pressure, ICP.
What are the classic symptoms of raised ICP in a child?
The classic symptoms include headaches, which are often worse upon waking in the morning or may awaken the child from sleep. Vomiting, which is often projectile and may occur without preceding nausea, especially in the morning. And potentially papilledema, swelling of the optic discs, seen on eye exam. In infants with open fontanelles, you might see irritability, lethargy, and an enlarging head circumference. Very late or severe signs can include the concerning Cushing triad, hypertension, high blood pressure, bradycardia, slow heart rate, and altered respiration.
The sources mentioned a few unique syndromes tied to specific locations.
Yes. For example, tumors arising in the diencephalon, hypothalamus-thalamus region, can sometimes lead to diencephalic syndrome. This is characterized, paradoxically, by profound emaciation and failure to thrive despite apparently adequate caloric intake, sometimes coupled with unusual alertness or euphoria and vomiting. Tumors in the pineal region can compress the tectum of the midbrain and cause Perrineau syndrome, which is a very specific paralysis of upward gaze, sometimes accompanied by pupillary abnormalities. Recognizing these specific syndromes can help pinpoint the anatomical location even before imaging confirms it.
What are the most common types of brain tumors in kids?
The most common types overall are astrocytomas, which can range from low-grade, like pilocytic astrocytoma, often curable with surgery alone, to high-grade gliomas. Second most common are medulloblastomas, which are malignant embryonal tumors arising exclusively in the cerebellum, posterior fossa. Other important types include ependymomas arising from the lining of the ventricles, brainstem gliomas, and craniopharyngiomas, benign but challenging tumors near the pituitary gland.
Any genetic links for brain tumors?
Yes, certain genetic syndromes predispose children to brain tumors. For instance, neurofibromatosis type 1, NF1, is strongly associated with optic pathway gliomas and other low-grade gliomas. Liefral-Mini syndrome, P53 mutation, increases the risk of various tumors, including gliomas and medulloblastomas. Tuberous sclerosis is associated with subpendymal giant cell astrocytomas.
What does a multidisciplinary treatment typically involve?
It absolutely requires a multidisciplinary team. The first step is usually maximal, safe surgical resection. The goal is to remove as much tumor as possible without causing unacceptable neurological damage. Surgery also provides tissue for definitive diagnosis and molecular testing, which is increasingly important for classifying tumors and guiding therapy. Often, surgery also aims to relieve hydrocephalus, perhaps by placing a shunt or performing a third ventriculostomy.
And after surgery?
Radiation therapy plays a crucial role for many malignant brain tumors, like medulloblastoma, high-grade glioma, ependymoma, especially in children over age 3, as radiation is particularly damaging to the developing infant brain. Modern radiation techniques, particularly highly conformal methods like intensity-modulated radiation therapy, IMRT, or proton beam therapy, are favored whenever possible to precisely target the tumor while sparing surrounding healthy brain tissue, aiming to reduce long-term cognitive and endocrine side effects.
What about chemotherapy?
Chemotherapy is also a key component for most malignant brain tumors. It's often given concurrently with radiation and/or sequentially after radiation. For some high-grade tumors like medulloblastoma, protocols may involve high-dose chemotherapy followed by autologous stem cell rescue, similar to neuroblastoma treatment. The specific drugs used depend heavily on the tumor type and histology.
Okay, let's discuss the histiocytoses next. These sound like a diverse group of proliferative disorders, not exactly typical cancers.
That's a good way to put it. They involve the proliferation of cells from the monocyte and macrophage dendritic cell lineage, the histiocytes. The main one we see in pediatrics is Langerhans cell histiocytosis, or LCH.
Is LCH malignant?
LCH is technically considered non-malignant, or perhaps borderline malignant, but it involves the clonal proliferation of Langerhans cells, a type of dendritic cell normally found in the skin. The hallmarks are the presence of characteristic Burbeck granules, tennis racket-shaped structures, seen on electron microscopy, and the cells express specific surface markers like CD1A, S100 protein, and Langren.
Where does LCH usually show up?
The most common site of involvement, seen in about 80% of cases, is the skeleton. It typically presents as single or multiple lytic lesions, basically holes punched out in the bone, which can occur in any bone but are particularly common in the skull, femur, ribs, and vertebrae. These can cause pain, swelling, or pathological fractures.
Can it affect other organs?
Yes. LCH can be single system, involving only one organ system like bone only or skin only or lymph nodes only, or multi-system, involving two or more organ systems. Multi-system disease can involve skin, rashes, lymph nodes, liver, spleen, lungs, pituitary gland causing diabetes insipidus, bone marrow, and CNS.
How does the prognosis vary?
Prognosis is entirely dependent on the extent of the disease and, importantly, the involvement of certain risk organs. Localized single-system LCH, like a single bone lesion, often has an excellent prognosis and may resolve spontaneously or only require localized therapy, like curettage or low-dose radiation. Even multi-system disease without involvement of risk organs, liver, spleen, hematopoietic system, generally does well with treatment.
So when is it dangerous?
However, multisystem LCH with risk organ involvement, especially occurring in children under 2 years of age, carries a significantly poorer prognosis and behaves much more aggressively. These patients require intensive systemic chemotherapy, usually involving drugs like vinblastine and prednisone, often for a year or more. CNS involvement also carries significant long-term morbidity.
Okay. And what about its far more aggressive and often fatal relative hemophagocytic lymphohistiocytosis, HLH?
HLH is a different beast entirely. It's not a cancer in the classic sense at all, but rather a life-threatening syndrome of excessive, uncontrolled, and inappropriate immune activation. It can be primary, familial, due to genetic mutations affecting cytotoxic lymphocyte function, or secondary, triggered by severe infections like EBV, rheumatologic diseases, or malignancies.
What happens in HLH?
Essentially, the immune system goes haywire. Cytotoxic T lymphocytes and macrophages become overactivated and can't be shut down properly. They infiltrate organs and release massive amounts of inflammatory cytokines, a cytokine storm leading to multi-organ damage and failure. It's a true systemic catastrophe.
How is it diagnosed? It sounds like it could mimic severe sepsis.
It can, which makes rapid diagnosis crucial. Diagnosis requires either molecular confirmation of a known causative genetic mutation or, more commonly, meeting 5 out of 8 specific clinical and laboratory criteria established by the Histiocyte Society.
What are those criteria?
The 8 criteria reflect the widespread inflammation and organ damage. 1. Persistent fever. 2. Splenomegaly, enlarged spleen. 3. Cytopenias affecting at least 2 cell lines, anemia, thrombocytopenia, neutropenia. 4. Hypertriglyceridemia, high fasting triglycerides, and or hypofibrinogenemia, low fibrinogen. 5. Hemophagocytosis, seen in bone marrow, spleen, or lymph nodes. Macrophages engulfing other blood cells, though not always found. 6. Low or absent NK cell activity. 7. High ferritin, a marker of inflammation often extremely high, 500 or even 10,000 Hodney-Dollar is a key clue. And 8. High soluble CD25, soluble IL-2 receptor, indicating T-cell activation. Treatment involves aggressive immunosuppression, steroids, adipocyte cyclosporine, and often requires allogeneic stem cell transplant for familial forms.
Finally, for this section, we absolutely must be prepared for those oncologic emergencies. Let's quickly recap the management for tumor lysis syndrome.
Right. TLS, as we mentioned, is that metabolic chaos caused by the massive rapid release of intracellular contents when tumor cells lyse, either spontaneously or with treatment initiation. It's most common in rapidly proliferating cancers like Burkitt lymphoma or high-count ALML.
And the key metabolic issues.
The 4 life-threatening electrolyte and metabolic disturbances are hyperkalemia, hypotassium, which can cause fatal cardiac arrhythmias, hyperphosphatemia, high phosphate, hypocalcemia, low calcium, secondary to the high phosphate, and severe hyperuricemia, high uric acid from nucleic acid breakdown, which can crystallize in the kidneys and cause acute kidney injury.
How do we manage it rapidly?
Management requires anticipating the risk and acting proactively. Key steps include 1. Aggressive intravenous hydration to maintain high urine output and flush the kidneys. 2. Medications to lower uric acid. Allopurinol inhibits uric acid production, or, more effectively for established hyperuricemia, resburicase, an enzyme that rapidly breaks down existing uric acid. 3. Frequent monitoring of electrolytes and renal function. 4. Correction of electrolyte abnormalities, for example, managing hyperkalemia. Dialysis may be needed in severe cases. Immediate recognition and management are non-negotiable.
Okay. And the compressive emergencies. Superior vena cava syndrome.
Superior vena cava (SVC) syndrome results from compression or obstruction of the SVC, the large vein returning blood from the upper body to the heart. In pediatrics, it's most often caused by a large mediastinal mass, typically from T-cell ALL or T-cell lymphoblastic lymphoma.
How does it present?
It presents with swelling of the face, neck, and upper extremities, visible distended veins on the chest wall, shortness of breath, dyspnea, cough, and sometimes headache or dizziness. Symptoms are often worse when lying down. It can progress to airway compromise, making it a true emergency.
What's the urgent response?
The urgent response involves 1. Securing the airway if compromised. 2. Obtaining a rapid tissue diagnosis if safely possible, though sometimes treatment must start based on strong clinical suspicion, as anesthesia can be risky. 3. Administering high-dose intravenous dexamethasone, a potent steroid, immediately to try and shrink the tumor volume and reduce associated inflammation swelling. 4. Initiating definitive treatment, chemotherapy or sometimes emergency radiation, as quickly as possible once the diagnosis is confirmed or highly suspected.
And the ever-present threat of infection during treatment. Febrile neutropenia.
Yes. Febrile neutropenia is defined as a single oral temperature of 38.3 degrees C, 101 degrees F or higher, or R, a temperature of 38.0 degrees C, 100.4 degrees F, sustained for over an hour, occurring in a patient with neutropenia, usually defined as an absolute neutrophil count, ANC, below 500 millimeters, or below 1,000 millimeters, and predicted to fall below 500.
Why is it such an emergency?
Because neutrophils are the body's primary defense against bacterial infections. Without them, a seemingly minor infection can rapidly progress to overwhelming sepsis and shock within hours. The usual signs of infection, like pus formation, may be absent due to the lack of neutrophils. Therefore, fever is often the only sign.
So what's the immediate action?
It's considered a medical emergency requiring immediate action. The standard of care is to promptly administer empirical, best guess, broad-spectrum intravenous antibiotics that cover common bacterial pathogens, especially gram-negatives like Pseudomonas, typically within 60 minutes of presentation. Cultures, blood, urine, etc. should be obtained first, but treatment must not be delayed waiting for results. Delay can be fatal.
We've spent a lot of time detailing how remarkable the cure rates are now, often exceeding 80%, especially for all. But now, we absolutely must confront the significant cost of that success. What defines survivorship care today?
Survivorship is essentially the commitment to lifelong vigilance and care after the cancer treatment is completed. The stark statistic is that a large proportion, potentially up to half or even 2/3 by some estimates of all childhood cancer survivors, will eventually experience at least one significant clinically relevant late effect resulting directly from their primary cancer therapy, chemo, radiation, surgery.
So the goal isn't just cure anymore.
The goal has evolved. It's now to achieve cure while minimizing undue lifelong morbidity and maximizing quality of life. We want survivors, not just patients who are cured but chronically ill.
What are the main goals of a formalized survivorship program then?
The core goals revolve around several key areas. 1. Systematic follow-up and risk-based screening for known potential late effects, based specifically on the treatments each individual received. 2. Patient and family education about their specific risks and the signs symptoms to watch for. 3. Promotion of healthy lifestyles, diet, exercise, avoiding smoking, which can mitigate some risks. 4. Ensuring smooth integration back into school, work, and society, addressing any psychosocial or learning issues. 5. Providing appropriate referrals for specialized care like endocrinology, cardiology, fertility preservation counseling, or neuropsychology. Generally, a survivor is defined as someone disease-free for 5 or more years off therapy, but surveillance for late effects starts much earlier.
Okay, let's detail some of the most significant specific late effects, starting with growth and endocrine problems.
Right. Radiation therapy to the brain, particularly involving the hypothalamic pituitary axis, which controls many hormones, is a major culprit. It can severely impact growth hormone production, leading to short stature and growth failure that requires growth hormone replacement therapy. Cranial radiation can also cause deficiencies in other pituitary hormones, leading to hypothyroidism, adrenal insufficiency, or problems with puberty.
Puberty can be affected.
Yes, both cranial radiation and certain chemotherapy agents, especially alkylating agents, can cause gonadal dysfunction, leading to either delayed puberty or, sometimes counterintuitively, precocious early puberty. Infertility is also a major concern.
Let's talk about the dose-dependent damage to vital organs.
Many of the essential life-saving chemotherapy drugs also carry the greatest long-term risk to organs. The classic example is the anthracycline class of drugs like daunorubicin and doxorubicin, which are fundamental to protocols for all AML, lymphomas, sarcomas, and Wilms tumor.
And their main risk.
They carry a significant dose-dependent risk of cardiotoxicity. This involves irreversible damage to the heart muscle, which can manifest decades later as arrhythmias, reduced ejection fraction, or chronic congestive heart failure. Lifelong cardiac monitoring is essential for survivors who received anthracyclines.
Other organs at risk.
Other treatments can cause pulmonary fibrosis, lung scarring, often linked to the drug bleomycin used in Hodgkin lymphoma, or chest radiation. Certain drugs or abdominal radiation can lead to chronic liver or kidney dysfunction. Hearing loss, ototoxicity, is common with platinum-based chemotherapy, like cisplatin, and sometimes cranial radiation.
Reproductive capacity and fertility is another huge concern, especially regarding alkylating agents you mentioned.
Yes, the alkylating agents like cyclophosphamide, ifosfamide, busulfan, procarbazine are highly gonadotoxic. They cause dose-dependent damage to germ cells, sperm precursors in males, egg follicles in females, which can lead to infertility later in life.
Does being treated before puberty offer protection?
It's important to note that, contrary to some older beliefs, being treated pre-pubertally does not fully protect boys from germ cell damage caused by high cumulative doses of these agents. Many will still have impaired sperm production. For girls, the good news is that prepubertal ovaries do demonstrate somewhat more resistance to the damaging effects of radiation than postpubertal ovaries. But radiation doses exceeding 20 Gray to the pelvis will still likely cause irreversible ovarian failure and infertility. Fertility preservation options like sperm banking or egg ovarian tissue freezing should be discussed before treatment whenever feasible.
And perhaps the most feared long-term threat, the development of a completely new cancer. A second malignant neoplasm, SMN.
Yes, the risk of developing an SMN is significantly elevated in childhood cancer survivors compared to the general population, and this risk increases over time, often reaching its peak 20, 30, or even 40 years after the initial cancer therapy. It's one of the leading causes of late mortality.
Are there specific patterns linking treatments to second cancers?
Yes, we see two fairly distinct patterns. The first is the development of secondary therapy-related acute myeloid leukemia, TAML, or myelodysplastic syndrome, TMDS. This type is specifically linked to prior exposure to alkylating agents and or to polymerase II inhibitors like etoposide. Therapy-related AML tends to have a relatively short latency period, often appearing within 2 to 10 years after the initial treatment.
And the second pattern?
The second and increasingly common pattern is the development of secondary solid tumors. These include cancers like breast cancer, thyroid cancer, sarcomas, skin cancers, melanoma and non-melanoma, and secondary CNS tumors. These are strongly linked to prior radiation therapy, with the risk being highest in the tissues that were directly within the radiation field.
And latency is longer.
Yes, these radiation-induced solid tumors typically appear with a much longer latency period, often 10, 20, or even 30-plus years after the radiation was given. The risk of breast cancer following chest wall radiation, for example for Hodgkin lymphoma, is particularly high and starts at a young age, necessitating early screening. This highlights why minimizing radiation doses and volumes is so critical in modern pediatric oncology.
Finally, let's just wrap up with a quick look at the role of bone marrow transplantation, BMT, or hematopoietic stem cell transplantation, HSCT, as it's often called now, in modern pediatric oncology.
Right. HSCT remains a vital, often curative treatment option for many high-risk refractory or relapsed hematologic malignancies, certain solid tumors, and some non-malignant conditions like severe aplastic anemia or primary immunodeficiencies. We generally distinguish between two main types based on the source of the stem cells.
Sure.
First is allogeneic HSCT. Allo means other. So this uses stem cells collected from a donor, ideally a genetically matched sibling, but often a matched unrelated donor, MUD, found through registries, or sometimes a haploidentical half-matched relative like a parent or umbilical cord blood.
What are the pros and cons of allogeneic transplant?
The primary risks of allogeneic HSCT are graft versus host disease, GVHD, where the donor's immune cells, the graft, recognize the patient's tissues, the host, as foreign and attack them, which can be debilitating or fatal. There's also the risk of infection during the prolonged period of immunosuppression needed to prevent GVHD and rejection. However, the major therapeutic benefit, particularly for leukemias, is the powerful graft versus leukemia GVL effect, or graft versus tumor effect. This is where the donor immune cells actively recognize and destroy any residual malignant cells in the patient, significantly reducing the risk of relapse compared to using the patient's own cells. Allogeneic HSCT is the mainstay for treating high-risk or relapsed AML and AL, and conditions like JMML or severe aplastic anemia.
Okay. And the second type, autologous transplant.
Second is autologous HSCT. Auto means self, so this procedure uses the patient's own hematopoietic stem cells. These cells are collected from the patient's blood or bone marrow earlier, often when they are in remission, and then cryopreserved, frozen. The patient then receives ultra-high-dose myeloablative marrow-destroying chemotherapy, sometimes with total body irradiation, designed to kill any remaining cancer cells. Afterwards, their previously collected stem cells are thawed and infused back into them to rescue their bone marrow function.
What are the advantages and uses of autologous transplant?
The main advantage of autologous HSCT is that there is no risk of GVHD or graft rejection, since the cells are the patient's own. This allows oncologists to safely administer much higher, potentially more curative doses of chemotherapy than could be tolerated otherwise. It doesn't provide a GVL effect, however. Autologous HSCT is typically employed as a consolidation therapy for certain high-risk solid tumors, most notably high-risk neuroblastoma, and sometimes for relapsed lymphomas like Hodgkin or NHL or Ewing sarcoma, where the primary goal is to overcome chemotherapy resistance with dose intensity. So I think to truly master this domain as the listener wants, you absolutely have to appreciate this tremendous tension that's inherent in pediatric oncology today. It's the constant balancing act. On one hand, the necessity of using these really aggressive, intensive, multimodal treatments to secure that initial life-saving cure. But on the other hand, the simultaneous need for adopting lifelong vigilance and proactive management to mitigate the very high probability of significant long-term morbidity and mortality in these growing numbers of survivors.
It really is a remarkable field, and the genetic specificity is just astounding. The fact you mentioned earlier that a single translocation, T1517, in AML completely flips the treatment script from general chemo to specific differentiation agents like ATRA and arsenic, and shifts survival rates from maybe 40% to over 90%, well, that just shows us exactly where the future of medicine is heading, doesn't it? Precision based on biology. But let's leave you, the listener, with this ongoing fundamental challenge. It really defines the cutting edge of pediatric oncology right now. We now know with absolute certainty that the very drugs and the radiation we use to save a child's life today directly increase their risk, sometimes dramatically, of developing a second, completely separate cancer, potentially 2 or 3 decades down the line. The core ethical and clinical mission for the field remains crystal clear. How do we continually adjust and refine these highly effective but also high-risk primary therapies to systematically reduce that devastating burden of secondary malignant neoplasms without ever compromising the incredibly high primary cure rates that we've worked so incredibly hard over decades to achieve? It's a profound balance that medical science and society must continually strive to negotiate.